Good morning.
Good morning.
Good morning.
I'm enjoying the sunshine today. I wish we had had it this past weekend, but a nice way to start the week off.
Sana, I see you have your hand up.
By mistake.
Oh, no worries. Hi, everyone. Hope everyone is having a great sunny start to this day. We'll give folks a few minutes to join.
Welcome everyone. Apologies for my voice. I'm getting over a cold. Also, I was trying to figure this out right before this meeting, but I sent out the agenda, but I got a couple of messages from people. So it seems like even though it looks sent on my end, it's not showing up on your end. So I'm still going to try to send it out because it also has the rulemaking packet, but I'll try to figure it out while we're doing our breakout groups for introductions. My apologies. I'm not quite sure what's happening. And I'm just looking to see who we have to see if we have a good critical mass of members. Let's give folks another 30 seconds to join. Okay. Um, for those who don't know me, I realized I was already talking, but didn't introduce myself. My name is Kathy Kilring Del Rio. I use she, her pronouns. I'm the Advocacy and Programs Director at Maine Equal Justice. I also chair the MAC. Um, and again, for those who just joined, my apologies about the agenda. I thought it was sent, and it looks sent on my end multiple times actually. But for some reason it's not sent. So I'm going to try to figure that out. Um, but we always start off with doing breakout groups for introductions. And so, Kayla, you're here, right? Oh, yes, I see you.
Right here.
Can I have you do that?
Absolutely. I'm going to go ahead and start our breakout rooms. There will be 3 to 4 folks in each room. And today we'll ask you to share your name, organization, and what brings you to the MAC today, and how you're arriving today in 2 words. And since I won't be in a breakout room, I'll go first. My name is Kayla Sargent. I'm the Associate Director of Strategic Planning and Communications here at the Office of MaineCare Services. And I am arriving today feeling creative and caffeinated. I'm going to go ahead and launch your breakout room. And
Thanks,
this will
Kayla.
be about a 10-minute exercise at most, but I'll give a 2-minute warning before we call everybody back.
Kayla, I'm gonna not join and try to figure
Okay,
out what's going on with my email.
okay, that sounds great. Thank you, Kathy, for working on that.
Yeah, no problem. Thank you.
Do you need support, Kathy? If it would be helpful if something's wrong with your email, do you want me to try and send it out?
Yes, I might ask you to do that.
Okay.
It's hard because it's like the whole list kind of, we should probably figure out a better way to have the list live, but um let me try to figure it out. And
Okay.
then if it doesn't work still, I'll give you the list as best I can.
Okay.
I do have like
Do
a
you want-
group that I usually send. Maybe that's the problem.
Yeah. Do you want me to hang out here just in case?
If you
I
don't
don't
mind,
mind.
that'd be great, Adam.
Yeah.
Thank you.
Hi, Vicky. Thanks for joining. We've just gone to breakout rooms, but we might be able to get you into one still. Excellent.
I just added Vicky to room 8, so that should be popping up for you to join. Vicky, we're just doing introductions in
Okay.
small groups.
All right. Thanks.
Thank you.
You know what I think might be the problem is the attachment. So I'm gonna try again to send the agenda just in the body of the email, but then I had started blind copying people because the list had gotten so long, but I'm not gonna blind copy people this time so that Adam or maybe Lisa or Kayla actually could do this. If one of you could reply with the rule making packet, because I apparently can't send the attachment, seems like what's getting stuck.
Okay,
Because I just sent
sure.
another email and it went through, but it didn't have an attachment. So I think that might be the problem.
Okay.
All right, hold on a second.
Would you like me to do that, Kayla, or do you want to
That would
send it?
be,
Yeah,
that'd be
okay.
great if you don't mind, Lisa.
Sure.
Okay, thank you.
Yeah.
Hi,
Hi,
Rachel.
welcome,
Thanks for
Rachel.
joining. Oh, sorry, Lisa.
Sorry.
Rachel, I just added you to room. Oh, all right. It looks like she saw and joined.
Smooth sailing.
I'm going to go ahead and give folks a 2-minute warning.
Kathy, do you want me to try replying to one of your older emails and attach the rule update packet to an older email?
Sorry, Lisa, I just realized that I put in the agenda, but then didn't put in the blog post that I was supposed to share. So when I was like redoing the email. So let me I'm gonna hit send right now.
Cool.
Oops.
Hi, Brenda. Welcome. Thanks for joining. Folks are out in breakout groups, but they're about to come back.
Did that work, Lisa? Can you see it yet?
Yay, success. Yeah, it just came
Okay,
through. I'll
great.
reply to
Thank
all.
you.
Thank you.
Glad that worked. We'll have to look into that. The communications with the Mac has been on my list of things to think about, like what
Yeah,
are some possible solutions that maybe aren't manual, but maybe we can follow up at our next
yeah,
monthly check-in or offline.
yeah.
I'm going to go ahead and close the rooms, and so folks should be all trickling back in over the next 60 seconds.
Welcome back, folks. We're just waiting for the other groups to finish closing out.
It looks like we have an AI note taker in the room that does not match any participant names. If Edward's note taker through Otter AI is your note taker, could you please chat me so that I know? And if I do not get a chat, we will be removing that note taker from the meeting.
All right, welcome back, folks. Again, my apologies. For those who came in late, my name is Kathy Kilrain Del Rio. I am with Mean Equal Justice and I chair the MAC. Um, and I just wanted to apologize again for some reason the email with the agenda hadn't gone out in advance. And people notified me about it, but it still wasn't working. But we figured out the problem was the attachment. So I have re-emailed the agenda. Hopefully you got it. And then Lisa Weaver kindly offered to reply to that email to send the attachment with the rulemaking packet. So you should have that in your email. But also I'll just review the agenda real quick for folks who maybe can't see it. We just did our quick introductions. We're gonna next do updates from the Office of Family Independence. Then we'll do updates from Main Care. And then we're going to do actually some additional updates from Main Care some policy updates. Then we do want to talk about the Provider Health Pass portal update. We'll get some updates, a lot of updates from the Beneficiary Advisory Council. We'll also get some updates around communications that are coming both from MaineCare and OFI, around changes that people should be aware of. And then we'll finish up with some housekeeping and a quick check-in about our new requirement that we have to do an annual report for the MAC. And then just a reminder that our next meeting is July 7th. And you should also have all that in your email. So hopefully you won't need to be reminded of that. And with that, I am going to pass the mic over to Ian Yaffe from the Office of Family Independence.
Great, good morning. Thanks for having me today. Wanted to share a couple of updates for you. Happy to answer any questions you have, but I had a couple of brief updates on just kind of where we're at for overall application renewal processing timelines, how things are looking at our call center, and some staffing changes that we're working on for the summer. So starting in that order, we've had a pretty good quarter, or almost a couple of quarters here for 2026. On the application side of OFI, this is across all programs. So, whether it's a MaineCare only application, a SNAP application with a MaineCare component, or a TANF application, typically, which has a SNAP and MaineCare component. Nearly all of our applications have MaineCare on them, but they get processed in different orders sometimes based on available staffing. But the good news here is that since January, we have, generally speaking, processed more applications than we've received that week. So we've been bringing our backlog of applications down week over week, roughly 6,000 fewer of those waiting to be acted on now compared to January, when we had a pretty large backlog of applications, which coincided with a period of time where we were receiving more applications than usual, plus all of the open enrollment referrals from the marketplace. So we're now pretty much on the other side of that. And to put it into context, we typically receive anywhere from 2,000 to 3,000 applications a week. So when we have 10,000 applications waiting to be processed, that represents roughly 3 weeks worth of submittals, or 10,000 would be, it depends on the week, but 3 to 4 weeks worth of submittals when we share some of those numbers. That's just the volume here. So generally speaking, things have been looking good here on the application and renewal side, where we have been clearing the backlog of work, and things are getting closer to their normal processing times of between 30 and 45 days, depending on what the application is. Some applications get done a lot faster, particularly MaineCare only applications, where we can process them in one touch. We look at it, we have all the information we need, we can do all the verifications, and then we can make a decision. Those may get processed faster. But a lot of applications require multiple touches. We look at the application or renewal, and then we need additional information. So we reach out to the member to let them know we need additional information. And then we have to wait for that information to come back. So all of that is included within the timeline. And again, the real summary here is just that it has improved over the past 5 months. On the call center side of things, I would say the summary there is that there's not much changes. Earlier in the year, we had a couple of weeks where the call center was looking particularly challenging for folks. We had some technology issues and then year-end staffing issues. But largely speaking, the wait times have been consistent for the past couple of months. And we're generally seeing around a 15-minute wait time for main care only calls and around a 30-minute average wait time for SNAP related phone calls, including main care questions from SNAP households, which have to go to that part of OFI. But that's generally been consistent here over the past several months. And again, people experience different wait times here. That's the average. There are some folks who may get their calls answered really quickly, particularly in the morning when we have people starting their day on the call center, and we can clear a lot of calls out when you have a lot of workers starting at the same time. And then the wait times tend to build over the course of the day. So in the afternoon, people may experience longer wait times, but it's all based on how many calls we're getting. We typically have the same number of people on answering the calls, so it's more of a volume question for what people's wait time would look like. And then we have two significant staffing changes that we're looking to implement over the summer. One of those is already underway, and that is that we're standing up a dedicated TANF unit at OFI. So currently, TANF households will call and be processed by any of roughly 200 eligibility specialists who are trained in TANF. And we are in the process of selecting staff to be in dedicated TANF positions so that over the summer, that will change to there being closer to 40 eligibility specialists who work with those households who typically have to reach out to us much more often than other households. And we expect that this will bring some more consistency for clients and TANF recipients when they have questions for us. And it will also kind of separate out. Right now, if SNAP is behind, then TANF is also behind, and this will mean that TANF is sort of resourced for the appropriate level of staffing for volume. And if SNAP is running a delay, that doesn't automatically mean that TANF households experience a delay. So there won't be really any change in terms of what people do to reach out to us. It's still the same phone number, still the same offices. It's more that on the back end, there will be a smaller group of people answering those calls, which we hope will provide greater consistency and make it easier for us to sort out issues that may happen between OFI and FedCap. And we're pretty in the TANF weeds here, but just letting you know that that's something happening and that that will impact main care members who have TANF. And we expect it will be a positive change, but we'll have more information once that's done. And again, there's not really anything different that people do. All the stuff that you can do in a regional office today, you can still do in a regional office once this is done, and the phone number that you call is going to be the same. It's really just that there'll be a smaller number of people on the other end of that, instead of kind of people doing TANF for a week here and there, and then they don't do TANF for several months. And then on the other side, we have the governor signed into law the supplemental budget. So OFI will begin the process of hiring around 90 new, or exactly 90 new full-time staff here. That includes almost all eligibility specialists or supervisors for eligibility specialists. And we are hiring these new positions to get us ready for community engagement requirements next year, and also to help improve the SNAP payment error rate. And all of these things should mean that we see a greater improvement to call center wait times and timeliness of processing, because we'll just have more people. To put it into context, we have around 400 eligibility specialists today. So this is close to a 20% increase to OFI's eligibility workforce. Almost all of the new positions will be going to the sort of community side of OFI, which is generally speaking the side of OFI that you interact with. We're not expanding our specialty teams that we have. So we should have good news here to share over the summer. Once those folks get onboarded, the process of training them means that you won't see a significant difference in outcomes until the early winter, because folks need to get hired and trained, and then they'll be able to answer phone calls and process work. But we are timing everything with open enrollment for the fall and with being ready for community engagement requirements. So we expect to see some pretty positive improvement on the customer service experience that people have when they are reaching out to us. And we'll have a better sense of what you should expect we'll be able to share more about that over the summer once we finalize the hiring timeline. So that's all I have right now. I know there's other updates about some of the changes that we'll talk about later, so I didn't want to bring those up here. But I appreciate you listening and happy to answer any questions that you have.
Thanks, Ian. Leo, and then Kathy.
Thanks. Thanks, Ian. That was a great report, and I'm really happy to learn that you're going to have a lot more help in the future, and that you'll have a dedicated unit. I wonder if you could give us some perspective about how long it's taking to process main care applications that have a long-term care component to them, because I know that the eligibility determinations are sometimes a bit challenging.
I appreciate the question. I don't have it right in front of me. Generally speaking, we've been closer to 45 days for long-term care applications. Some of them extend over that timeline, particularly for getting a lot of the information back, but we still are generally speaking closer to that 45-day mark for long-term care. We don't have a lot of applications that go over that standard. We have a dedicated unit for long-term care as well, and they don't experience the same kind of wait times and sort of backlog challenges that you might see on the sort of community side. But I can get more information about that. I just didn't have it in front of me. It is something we track. I just didn't have it right in front of me.
Okay, that'd be interesting to see how many times or what the exceeding the 45-day processing limit is. And in my recollection is that if you don't meet that deadline, then the individual gets eligibility until you do determine whether they're eligible or not. Is that right?
It depends on the specific reason. That's generally true for main care applications, that if we don't act on them, that we move them into state funding. But some of that timeline depends on what we're waiting for. So I can get an answer on that one too.
Yeah. I mean, I just don't remember.
Yeah. There are also times, I know with long-term care, there are times where some of those longer applications are ones that there are times where we may hold an application open, such as when we're working on a placement, where it doesn't make sense for us to deny the application and then have somebody start from square one again. But I can get more information about, where those are at and what happens when it's over 45 days. And we do have some processes in place with long-term care facilities when there are applications that we need to act quickly on. We have some expedited pathways. I mean, if somebody needs a placement right away and they're just waiting on an eligibility decision from OFI, we can move quickly on those. And then we have an email box for some of those types of things that we're generally able to get responses out within 3 business days on. So again, some applications do go over that mark, but typically that's with a lot of communication with the facility, the member, or the authorized representative of why we're why we're doing that, or we're waiting on information. But again, we can get more information about that.
Great. Thank you very much.
Kathy?
Hi, Ian. Similar question just around My Main Connection. We used to see that it was faster decision when we applied through My Main Connection, but we've noticed that that doesn't seem to be true anymore. Could you speak to that?
Sure. I think so. When we receive those applications, they essentially go into the same queue to be worked. So an application received by My Main Connection today is going to get processed on the same timeline as an application received by paper today. The difference here is that the application received from My Main Connection was submitted today, and the paper application may have been submitted last week. So you're saving a couple of days on that side. And then when we send a notice of decision, if folks have elected to receive e-notices, they'll receive that notice of decision the next day on My Main Connection versus waiting for the mail. So the faster processing time for My Main Connection is typically just the time that is cut out from stuff being in transit to or from OFI, but it's not actually faster once we get it. There are cases where that might be true. Like if people provide a more complete application on My Main Connection versus an incomplete paper application, there's a chance that it might need less verification or less follow-up. But generally, once we get it, there's no difference between a paper application and when it will get looked at by us, and a My Main Connection application and when it will get looked by us.
I thought at some point I heard that AI was going to be used to make decisions with My Main Connection. Is that not happening at all, or not planning to be used?
Definitely not happening at all. I don't even think we're in the planning phases for that, but I wouldn't make any promises about where we go long term. But we're currently not using AI to make any decisions, and we have no planning process to even start thinking about that. There's a lot of guardrails in place that prevent us from doing that, including the state's own AI policies and some of the federal rules about who can make eligibility decisions and things like that. The one exception that I would say, and it's still not AI, so it's not an exception. Generally speaking, almost all of our eligibility decisions are made by a person, whether that's an approval or a denial. When MaineCare members go through the automatic renewal process, and they are automatically renewed, that means there's a computer automatically renewing you. It's not AI though. And people are still going through the same verification process and determining reasonable compatibility for eligibility. It's just we may not have a person reviewing that eligibility renewal. There are no automatic denials though. If somebody doesn't pass the automatic renewal process, a paper renewal form is sent out, and then a person will review that renewal form to determine eligibility. But that's still not AI, and that's the same automatic renewal process that we've been using for a couple of years now.
Thanks.
Thank you, Ian. And before we pass it over to Michelle Probert for updates from MaineCare, I just want to, around the AI decision making, I know there are some states where I don't think it's AI, but it's like different algorithm things that they use and have at times had really problematic outcomes for people once computers are making the decisions without any human input. So hopefully if we get to the point where we might be making those kinds of decisions around AI, we'll have a bigger conversation as part of the MAC.
Yeah, I think we're so far away from, I think, starting that conversation
Yeah.
that it's not worth
Yeah.
going down right now. We are certainly involved in a lot of those conversations with other states about what they're doing, but a lot of the uses of AI in the space are less in the decisioning process currently and more in the like system design or other things. So that and the only planned use of AI that we have for the near future would be around trying to create some sort of easier way for people to interact with the rules and ask questions of us. That would be our first foray into AI. Is here's a way to search the rules without having to know how to read them, but not anything that's connected to your data, not anything that means that you're talking to a chatbot before you talk to us. So we still have very much people at the center of eligibility work here, and that will continue to be the case.
Thank you. Michelle?
Thanks, Kathy. Thanks, Ian. Good morning, everybody. My name is Michelle Probert. I use she, her pronouns. I am the director for the Office of MaineCare Services, and nice to see folks this morning. Thanks for being here. All right, so I will move through my updates. This was covered in part by Ian as some of his items related to legislative action, but just as a reminder to everybody, the 132nd legislature did adjourn last week on April 29th, which formally concluded our second regular session of this biennium. Governor Mills signed the supplemental budget earlier on April 10th. And since there was not broad bipartisan support for the budget and related bills, the effect of that is that there's a 90-day delay until the resulting bills and budget go into effect. My understanding is that Maine is pretty unique in this respect. So the supplemental budget, as well as resulting bills from this session, will officially take effect on July 29th. I have been asked to join the Rate Systems Subcommittee meeting on May 11th to provide an overview of what passed that relates to MaineCare, both in terms of bills and budget initiatives. So I will be delving into more detail on that topic at that meeting. Okay, I will give a related update. This has gone out in e-messages, but beginning next Wednesday on May 13th, we are going to be temporarily withholding certain MaineCare payments. This is because as there was last year, there is a shortfall for fiscal year 26 that we are currently in. The governor indicated that we needed funds in order to cover the shortfall and therefore pay providers in full in her submission of the supplemental budget request. Again, we did not the budget did not pass at a margin that would have allowed us access to those funds this fiscal year. So as a result, unfortunately, we are in the position again of needing to withhold certain payments. We are taking an approach that is extremely similar, almost identical to the approach that we took last year. We are starting a bit later than we did last year because the size of the projected shortfall is estimated still to be a bit smaller than it was last year. Again, feel free to access e-messages on this, but list of the payment types that we will be temporarily withholding include prospective interim payments to critical access hospitals and private psychiatric hospitals. We will be withholding 30% of those payments. All high dollar hospital claims, which are defined as claims greater than $50,000. We are withholding payment for pharmacies that are large chains or out of state. And the same thing with large chain and out of state durable medical equipment providers. And we are withholding payment for out-of-state providers, except those right along the border who we officially consider as in-state, so out-of-state providers of hospital and ambulance services. We do not yet have precise information about when we're going to be able to release these temporarily withheld payments, but we do anticipate that it will be in early July. We meet at least on a weekly basis to monitor cash flow in and out of the MaineCare accounts. And if we are able to make more payments than anticipated this fiscal year, then we will. If it is looking like we're short, which we do not anticipate, or more short than we project, which we do not anticipate at this point, then we will reassess as appropriate and remain in communications as we go through this process. Last year, we had a lot of conversation about whether we would be expanding the withholding, especially if it would start to hit providers who tend to be more dependent on MaineCare revenue compared to their overall revenue. We did not end up having to do that last year, which was good. We do not anticipate nor plan to extend the withholding beyond the payment provider types that I just indicated in that summary. I will pause there in case there's questions.
Michelle, did you see the questions in the chat?
So I see what effect will this have on members. So one of the reminders that we included in our e-messaging is that providers per federal law are not allowed to turn away members nor charge members for their MaineCare services. And so providers are expected to continue to provide services to members as they're obligated to do so. I will say that when we did this last year, we did not hear reports of any impact to member access that we are aware of. If you do hear of or experience an impact, then please let us know. If that is pharmacy related, going through our pharmacy help desk probably makes the most sense, but you could also call member services. And Kayla, if you have any thoughts on how to best relay that information about potential member impact, then please share with the group.
Thanks, Michelle. Definitely member services would be the best first line. We will ask them to track those types of issues that come in so that we can track trends and try to see if there are certain areas or certain providers where it's cropping up. But I would also say if it's coming from a provider perspective, calling the Gainwell Provider Services helpline is also another good way to go.
Okay, I will keep moving forward. So for those who really are closely following Medicaid news, on April 23rd, so the week before last, the Centers for Medicare and Medicaid Services, CMS, sent letters to all state Medicaid agencies, as well as to all governors across the country, with a request that states develop and submit a 2-year provider revalidation plan with a priority on revalidating high-risk providers. I will say that since those communications, there has been a very high volume of conversations and questions around the scope and specifics of those communications. What I can say for certain is that all states need to respond by May 7th to acknowledge receipt of the letter from CMS and indicate their intent to act. And so Maine will be submitting that required response accordingly. There is a 30-day time window, business days, for submitting a full plan as requested to CMS for the validation. So again, there are lots of questions, not lots of answers at this point. So we are continuing to have conversations to understand the requirements and determine what the plan will be in the state of Maine. And we will communicate more once we have more certainty and helpful information to share. Any questions on that front? I will just acknowledge that provider revalidation is a time-intensive and often administratively burdensome process. We absolutely recognize that. We luckily have made, not luckily, through hard work in collaboration between Office of MaineCare Services and our partner Gainwell, we've made a lot of great strides in how quickly we are able to process provider enrollment applications. We've presented at this group in the past about those improvements. Obviously, having a directive from CMS on increased frequency, timelines, emphasis puts additional stress on the provider system as well as the department. So I just want to acknowledge that. Bobby?
So we did have a question from Bobby Martin.
Hi, thanks, Michelle. I was just curious, did you say revalidation of high-risk providers?
I said that the request puts an emphasis on prioritizing the revalidation of high-risk providers. And they did not define high risk, but are looking to states to define what high risk means.
Do you have an idea of what they're getting at?
That's a great question. I will say not really. There's again, different states have different approaches to categorization by provider risk, and CMS has expressed a lot of interest in provider revalidation of providers they consider to be high risk, and have been on social media about that, et cetera. But in terms of the specific request, they have not defined high risk. They have indicated that they expect states to make decisions and plans that are appropriate for the state-specific context. That's about all I can say on that front right now.
Fascinating. Thank you.
Laura?
Thank you. And good morning. And thanks so much for the updates, Michelle. I apologize. I'm on the road this morning. The only thing that I saw just in regards to the Bobby's question about, what does it mean when we're saying high risk, is the NPI number. And so I thought that was interesting and wondered if you could reflect on that related to the request.
I can share that CMS is, in addition to the emphasis on high-risk providers, they want to know what states are going to do around providers who do not have NPIs, which stands for National Provider Indices, if I have that correct. This is, from my understanding, a much bigger issue in some states than it is in the state of Maine, but that is an additional area of emphasis from the CMS communications. Okay. Seeing no more questions at the moment on that, I am excited to announce, for those who may not already be aware, that we are going to be hosting our first broad MaineCare Provider Conference. That is going to be on October 27th this calendar year, and we have capacity for up to 500 provider attendees. the theme for the conference is Stronger Together, Navigating Change Through Collaboration. We have for many years held annual delivery system reform forums, and those forums are going to be rolled up into this broader provider conference, but there will be, again, opportunity for providers broadly defined to participate in this year's event. We are excited about this opportunity. It's a great opportunity for providers to hear directly from OMS. We often get requests for clearer guidance on billing and documentation and program requirements, and this provides an in-person opportunity to speak to themes of requests that we are getting, as well as speaking to department priorities, and also for us to really be informed by group discussion, which happens through one-on-one conversations as well, by phone, etc. But when a group gets together, you often get to learn more. And then, as you may have inferred from the title of the conference, the upcoming federal eligibility changes are going to have the potential for broad impact on members as well as providers. We know that providers are a trusted source of information for members, and so it's really a critical opportunity for us to collaborate and partner together to navigate these changes. And we will have additional and earlier opportunities for that collaboration and education, but this in-person conference will provide a great opportunity to strengthen the impact, the positive impact that we can have on hopefully minimizing disenrollment related to the changes from last year's HR 1, also known as Big Beautiful Bill Act. We are collecting input internally right now on potential topics for presentations and sessions, and we will also be sending out a call for proposals in the near future. And Kayla has put a link to our provider conference website in the chat. And that is it for my updates this morning. Thanks.
Thank you. I think, Michelle, you're still up next with Henry Eckerson to talk about policy updates.
So I believe that Olivia is going to be partnering with Henry on that agenda item. Is that correct, Olivia?
Yes.
And
okay, great.
Actually, this gives me the opportunity, which I was going to chat Olivia about, but didn't quite get to this morning. I did want to make an announcement. So Olivia was previously our Associate Director of Delivery System Reform. It's been a few months now. Maybe Olivia can remind me of the specific date, but Olivia has been promoted into a new position for the Office of Main Care Services, which is the Deputy Director of Program and Policy. And so with that, Olivia is now responsible for what historically has been our delivery system reform unit, as well as our policy unit and rate reform pieces as well. And along with that change in scope for Olivia, many of you know Kristen Merrill. Kristen most recently has been acting as our Associate Director of Policy, but with some of our organizational changes, Kristen has also received a promotion as Associate Director of Program Implementation. And so her focus is in part still going to be on questions of federal authority as it relates to our main care coverage, but also more broadly making sure that we have strong processes for developing and implementing and operationalizing our programs and policies. And with Kristen's elevation into her new role. We will soon be hiring for a new senior manager position, or I should say reconfigured senior manager position under policy. And that new senior manager position will be focused on really like technical rule development. And I'll let Olivia add any additional context to that description as she would like, but thought that this was a good opportunity to inform folks of those changes, which we feel really good about, helping us to improve the efficiency of our office, as well as collaboration and making sure that we have sufficient resources to what is really a lot of work to both technically keep all the rules moving and the importance of really precise and clear language, but also having expertise around policy design and development and implementation, which is always more challenging than we often anticipate.
Thanks, Michelle, and congratulations, Olivia. I also just want to note real quickly that Ian put in the chat an answer around the long-term care timeline. So for folks who are interested in that. And I'll pass it over to you, Olivia and Henry.
Great. Thanks so much. And thank you, Michelle, for that additional information. Yeah, it's very exciting. I've been with MaineCare for 11 years and just moved into this level of position last fall. But I started as a policy writer out of my master's degree back in Maine. And then I've worked in both policy and then spent a lot of time working with a lot of you all in different contexts to improve our delivery system, improve our policies. And so I'm very excited to have this broad oversight over really the full cycle of how we get from an idea to implementation and consistency in the rules that support providers in doing what they do and members in accessing the services they need, which really just feeds really great into this conversation that Henry is going to really take the majority of the conversation around, which is about the 7 rules that were adopted 2 weeks ago regarding strengthening our children's behavioral health system. So what Henry is going to do today is really in response to requests from this group is to walk through the major changes that are included in these 6 children's behavioral health and some adult behavioral health related provisions of rule that changed in the recent weeks. He's going to really focus on changes that were made in response to the comments that we received from the public during the rulemaking process. So I'll leave that to him, but I wanted to start with just acknowledging that this has been a tremendous amount of work from all parties and the work that has really started long ago. So many of the changes that were part of these rules were ideas that were recommended or best practices that have been recommended for several years for the department to make changes to strengthen the children's behavioral health system. There have also been reform efforts that we've been working on collectively for several years, such as mobile crisis reform that got implemented with these rules. There was also bringing back past services, high fidelity wraparound that was a success in Maine in the past, but had been absent from the delivery system for several years. And then there were several really significant updates to rules that hadn't been updated in many years, sometimes up to 10 years. So it was just, I want to acknowledge that it was an enormous amount of work and an enormous amount of change all at once. And Henry's going to walk through a little bit of that timeline. But I want to thank you all for your participation, whether it was in the years leading up to some of these changes, and really in all of the comments that were submitted in response to the proposed rules, which were very instrumental in making sure that we landed on adopted rules that really reflect these items here on the slide of a better system for children's behavioral health services in the state of Maine. There is a blog that was posted on Friday that describes the process that led up to these rules and how the public comments were really, really highly valued and considered in adopting the final rules. As someone who spent a lot of time on these rules since the fall, it really is truly it's such an important part of the process. Every single thought that you all put forward in your public comments are individually considered and responded to. And we'll have at the end here the resources for you to go through in more detail if you want to look at how every single comment was considered and weighed in the final adopted rules. And again, I'll just turn it over to Henry to do that high-level summary, knowing that you have many other ways to interface with the department on some of your more detailed questions, and also just supporting you in the implementation of these new rules going forward, because it doesn't really end with the adoption of the rule. We know that there's a lot of operational conversations to be had, technical assistance, and that work continues. And yes, we will share a copy of these slides at the end.
Thanks, Olivia. And I assume I'm sharing the right screen.
Yeah, looks
Okay,
good.
great. Okay, so just to start with some background, in December of 2024, the state of Maine entered a settlement agreement with the U.S. Department of Justice that aims to prevent children and youth with behavioral health needs from unnecessarily entering or remaining in out-of-home placements. The settlement agreement had many implications for Maine Care rules. Most notably, the settlement agreement directed the department to implement a standardized single assessment process that determines which medium and high intensity behavioral health services children are eligible for, rather than determining eligibility for each service on a case-by-case basis. The settlement agreement also directed the department to bolster care coordination requirements, including requirements related to comprehensive assessments, individual service plans, and care coordinator responsibilities. It also contemplated, although did not precisely direct, the addition of new services, including a new mobile crisis service. And it also directed us to implement requirements for community providers that I will highlight later. Implementing the single assessment required rulemaking in each section of policy that covered a medium or high intensity service. And this necessitated doing 6 simultaneous rulemakings. 7 simultaneous rulemakings. Most of these rules had already been worked on for years and included many necessary changes unrelated to the settlement agreement. And as the January 30th deadline approached for us, it kind of became clear that we could not meet the deadline through standard routine technical rulemaking. So we opted to do 6 emergency rules that could become effective immediately, while simultaneously proposing 7 companion rules that would go through the standard rulemaking process that includes a comment period. So first, the Children's Behavioral Health Services Global Rule has a new section of the MBM, Chapter 1, Section 7, and its primary purpose is to implement the single assessment, but it also implemented other requirements required by the settlement agreement. It gives a high-level overview of the single assessment process from referral to authorization of services and identifies the level of care utilization system, or LOCUS, suite of instruments that is used during the assessment. It also explains the conditions under which Maine Care providers must offer to refer members to the single assessment and which providers are exempt from doing so. It requires community providers to make services available in time to prevent out-of-home placements and emergency department visits to the greatest degree possible, to develop and comply with contingency plans that outline the measures they'll take to ensure children have access to backup staff, and to have competency and appropriate training in the services they deliver. The rule also contains broad requirements related to limits on denying services, telehealth, data reporting, and reimbursement. The final adopted version of the rule was predominantly the same as the proposed and emergency rules, but we did make quite a few small changes, mostly to clarify requirements and processes. And just one example, we caveated that providers must minimize undue delays in delivering services to the greatest degree possible, considering certain uncontrollable constraints. As I mentioned before, the care coordination requirements, the settlement agreement required us to adopt many care coordination requirements, and these were put into sections 13, 92, and 97. They primarily aim to ensure that children receive the appropriate and preferred services in a timely manner to prevent out-of-home placements. These care coordination requirements include conducting an individualized needs assessment every 6 months, meeting in places and at times convenient for and preferred by the child and family, planning to ensure services are received timely, and notifying the state if necessary services are not received timely, identifying risks to leading to a potential out-of-home placement, developing an ISP within 30 days of the first meeting with the care coordinator, ensuring members understand how to raise issues with existing services or lack of services, ensures that certain components are included in ISPs, and requiring care coordinators to complete wraparound planning principles training. There are a number of other care coordination related requirements, but these are just some of the highlights. And adding these requirements for therapeutic foster care were constituted the vast majority of changes we made in Section 97. There were only a handful of other unrelated changes in the Section 97 rulemaking. So now into the other rules. Section 13 had not been opened since 2014, and we revised so much of the rule that we decided to repeal and replace it. In addition to the settlement agreement care coordination requirements, we expanded the covered service requirements, which were fairly limited before. We clarified in-person and telehealth requirements. We added substance use disorder diagnoses to the allowable diagnoses for children with behavioral health disorders. We updated the eligibility for children with developmental disabilities by removing references to outdated assessments and added the ASQ as a tool that can be used to establish eligibility. We created an eligibility category for members under 26 up to 30 days prior to and for at least 30 days following release from a carceral setting. We expanded case management to members with a history of homelessness. We added to the list of non-covered services and activity, added a provision permitting an overlap of services where services under Section 13 may be reimbursed for a period of 180 days while a member is in certain institutions. And we made many, many other changes, but these are just some of the highlights. A couple of the more significant changes we made in response to comment was to broaden the eligibility requirements for children with DD to align with the former rule. And we also reduced the frequency of in-person requirements and comprehensive assessments. And on to 28. The former Section 28 rule left a lot to be desired. The names and descriptions of the two services, commonly known as standard and specialized RCS, did not meaningfully describe or distinguish the services. The eligibility criteria for both was also quite broad and identical, despite being different, albeit related services. It also included a third service that was actually a part of specialized RCS, and the rule did not address the school-related versions of these services at all. And so all of these issues led to a lot of provider misunderstandings and questions and contributed to the large variance in the quality of services that providers delivered. So given these issues, Section 28, like Section 13, underwent a repeal and replace because of the volume of changes we made in the policy. However, it's important to note that the emergency Section 28 rule only added the few changes needed to implement the single assessment. The broader changes to the covered services and eligibility criteria were not included in the emergency rule and did not become effective until we made changes to the proposed rule in response to comments and was then adopted after department and OAG review. So the primary changes included changing the name of standard RCS to adaptive skills training and rewriting the service description to more accurately describe the service model. Also changing the name of specialized RCS to applied behavior analysis, or ABA, because ABA is the technical name of the service being delivered. And we also changed the service description as appropriate. We also removed the independently or separately covered kind of BCBA services and incorporated them into the ABA service description in the adopted rule without the previous limitations that were included in the former rule, because the BCBA services are included in the reimbursement for ABA services and are not separately billable. We updated the ABA eligibility criteria to more accurately identify the target service population and improve clinically appropriate service utilization. We added registered behavior technicians as direct care staff for ABA because they're specifically trained to deliver ABA. And among other school-related requirements, we clarified that prior authorization requests for school-related services, school-related 28 services, must include the IEP or IFSB prescribing the service. We did propose more restrictive eligibility criteria for adaptive skills training to ensure that the service was medically necessary for the children who qualified for it, but we removed those changes in response to many comments that expressed concern about the narrower criteria. And we hope that the single assessment process funnels some kids who may have ended up receiving 28 services into other services that are better suited to address their behavioral health needs, and that the improved Section 28 service descriptions and requirements improve the consistency of the quality of services delivered. All right, and Section 65. It's only 3 more to go. We changed, clarified, and added a lot of requirements in Section 65. We removed the definitions of functional family therapy and multisystemic therapy and added covered service subsections for them because they're distinct, separately reimbursable covered services. We removed crisis residential services and added a sunset date for crisis resolution, which I'll speak more about on the next slide. Clarified when providers can bill for the community and office outpatient service rates. We added a second level of substance use IOP services, and that service kind of reflects the intensity of a partial hospitalization program. We established a minimum monthly average of 3 weekly contacts for HCT and Children's Act, as well as exceptions to that contact requirement. We aligned opioid treatment program services with 42 CFR Part 8, which SAMHSA had revised in February of 2024. This included a lot of changes, including updating definitions, adding harm reduction principles, and changing the maximum initial dose of methadone. We also added multiple new PPP curriculums, such as Stepping Stones, which are parent training programs. We renamed and clarified the purpose of the previously named outpatient services comprehensive assessment, which was poorly defined and misused as a result. And we also clarified that outpatient service providers fluent in ASL can bill for the associated enhanced rate without an interpreter certification or license. These are just a few of the more significant changes. There were many, many others. And some of the primary changes we made in response to comments, you can see on the slide. We lowered the qualifying CalOCA score for MST. We did, make that ASL enhanced rate change that I had mentioned. We extended the time BHBs have to obtain certification from 90 days to 180 days. Okay, section 66. So main care previously covered two crisis services in section 65, crisis resolution and crisis residential services. Crisis residential was repealed from section 65 and added to section 66. The service remains essentially the same, but we added quite a few provider and service requirements, which previously only existed in contracts that OBH held with these providers. And we did this with the aim of OBH contracts eventually pointing to main care rule rather than contain additional separate requirements. Crisis resolution is how Maine Care reimbursed mobile crisis teams that are part of Maine's centralized mobile crisis system. This service will remain effective until June 30th, 2026 in Section 65 and will be replaced by the new Mobile Crisis Intervention Response Service that will become effective on July 1, 2026. The reason for the delayed implementation is that the new Mobile Crisis Service is not what we call an quote unquote any willing and qualified provider service. Instead, OBH issued an RFP for providers to deliver the new mobile crisis service in designated crisis districts, and only the providers who win the contracts will deliver the service. And these contracts will become effective on July 1 to coincide with the rule and the effective date of the new mobile crisis service. States were authorized to cover this new mobile crisis service by Section 1947 of Title 19 of the Social Security Act. And the mobile crisis services include individualized therapeutic intervention services available 24 hours a day, 7 days a week. They are delivered by a multidisciplinary team, which includes a crisis supervisor, dispatch coordinator, and crisis responders. The service includes initial encounters and aftercare. Initial encounters may be delivered through a one-person or two-person response, and the service components will include engagement, de-escalation, assessment and planning, intervention, and disposition. Initial encounters may be delivered in person in an office or on scene. Aftercare services are delivered following the initial encounter as clinically indicated and help integrate members in crisis into other behavioral health and substance use disorder services. The other new, quote unquote, new service is site-based crisis stabilization, which is really just another modification of crisis resolution. There are a handful of existing providers that deliver crisis services in crisis receiving centers or distinct crisis units within emergency departments. And with the repeal of crisis resolution and the introduction of the new mobile crisis service, we wanted to ensure that these providers can continue to receive reimbursement for the crisis services they deliver. The primary difference between the two services is that site-based, between crisis resolution and site-based, is that site-based must be delivered in one of the two aforementioned settings. The actual service includes standard crisis service components, which are the same components included in crisis resolution. And last but not least, Section 92. In addition to the DOJ care coordination requirements, the most significant change to Section 92 was the addition of high fidelity wraparound services. These are more intensive BHH services reflecting the high fidelity wraparound service model for children's behavioral health. Other changes included removing health home practices as providers, which were discontinued after the Primary Care Plus program was stood up in 2022. We altered some BHH responsibilities to improve behavioral and physical health integration. We introduced staffing ratios for the peer support, health home coordinator, and clinical team leader positions, and we removed the previous performance measure and added performance measures related to access to preventive care and quality of life. Some of the bigger changes we made in response to comment included removing the proposed increase in frequency of the comprehensive assessment. We added flexibility for providers to facilitate high fidelity service delivery. And we provided more time for providers to meet required peer staffing ratios and conduct member intakes. I know I had to talk very fast, and that was a ton of information. If you do want more information, there's lots of resources out there. You can access the finally adopted rules on the Secretary of State's website. You can access all the rulemaking packets that includes the comments and responses and the list of final changes made to the rules on the department's rulemaking website. The Commissioner's Office posted a couple blogs, and the Office of Behavioral Health also has a web page dedicated to the settlement agreement. And if you do want to get in touch with me, that's my email. So happy to take any questions.
Are there any questions, Rachel?
Hey, so I only have one question because I got lost in the weeds after public comment on this whole process. I'm not even going to deny that. So are we still doing like that increased frequency for evaluations for children's services? Because one of the biggest concerns I have is the fact that we don't have enough providers for triennial evaluations here. Even our local school district is a year and a half behind.
I think you're referring to the comprehensive assessments. We had previously had those at a kind of had a requirement to repeat those every 6 months, and in response to comments, we removed that requirement. There must be repeated annually, and if you're delivering section 1392, if you're delivering services in those two sections, and for TFC as well, therapeutic foster care.
Because I remember, like, with Section 28, there was a proposed, like, having to repeat the full neuropsychs more frequently in the beginning of things. I don't know if that changed, but that was the biggest concern our family had. Because my children are homeschooled. My daughter just joined the public school district. And even our school district is like, oh, no, we're still a year and a half behind in adding on to that list to even get kids evaluated.
If you're speaking about the comprehensive assessment, I mean, we do require like different types of assessments depending on the service, but for the comprehensive assessment, I don't think we proposed a change in section 28 to the frequency of that, and it's still a year.
I think it was the neuropsych.
Yeah, I think this was Henry, this was the change to how frequently, like, the eligibility had to be redocumented for the diagnoses that made someone eligible for 28.
Okay.
I know we made some changes to that. I don't want to misspeak, so let me look them up. But we did basically walk back some of those changes to make it in response to comments like that. That made it so that hopefully, once found eligible, the need to reassess eligibility was more reasonable. But let me find the exact change.
Yeah, you're golden. Don't rush on it. You can email me whenever. I'm just curious because my child receives Section 28 services. But we've called providers from Fort Kent to Kittery, and they're all booked out at least 2 years. So there's no way for me to get her a triennial in any reasonable amount of time without knowing that this was going to be a thing.
Any other questions? Okay. Well, thank you all. That was very comprehensive and appreciate it. I know it's an important topic to a lot of folks here. Next up, we wanted to share from Molly Slotsnik some information about the Provider Health Pass portal update.
Thank you, Kathy. Let me just bring my slides up for a moment here. Okay, hang on. I lost you. Give me a second. All right, can you see my screen?
Yes.
Okay, and if I do this, can you see the slide still?
It's the wrong
Uh,
view.
yeah, it's like the
We can
viewer.
see your notes too.
Okay. All right. Sorry, I'm not as adept at this as Henry was, clearly. All right, so I'm gonna do it this way. And we'll go like this. And it's gonna be hard for me to monitor the chat. So I probably will not be able to do this at the same time.
I'll try to keep an eye on the chat, Mom.
Okay, thank you. All right, so this will be a few minutes about an upgrade we are making to our claims processing system and a new online portal that is going to be coming along with that. I gave an update to this group about a year ago on this topic, but it was very introductory and high level at that time and said more information to come. So here is some of that more information. There is a lot of information in these slides. We can share these slides after. And we also ask that you keep an eye out for an e-message that we will send in the next, like this week or next week, that will have a lot of this information and even maybe some more details. So if you don't absorb it all right now, that's okay. There will be more information coming, but this is really just to give everybody a heads up of things that are coming, changes that are happening, and actions that we need users of the portal to take. So this is really just a reminder from the presentation I gave last year. HealthPass is our vendor partner Gainwell's proprietary name for the core claims processing functionality. So MIMS is our claims processing system, and HealthPass is the core functionality within that. We are upgrading from a version that is many years old to the latest and greatest version, and that will help our system as a whole be more secure and stable, and also give us some new functionality and allow us to be more nimble in making system changes in the future when we have regulatory changes we need to make, programmatic changes, operational changes. We started this project about a year and a half ago, more than a year and a half ago. It's a 2-year project. We are on track for implementation, which is really great news for a large technology project this far along. We are planning to go live with our upgraded system October 10th of this year, which is a Saturday. So most of the changes that will affect this group and our sort of provider and trading partner community as a whole are going to be changes to the online portal. That's what we refer to today as the HealthPass online portal. Most of the other changes are all just going to be in the back end and won't really have much effect on you. So I'm really focusing on changes to the online portal in this presentation and in the communications that will be forthcoming. So we will have a new version of the online portal, and it's going to have multiple provider and member benefits. We actually sent out a message in March that there's a message on today's portal that talks about those benefits, and I had shared some of those a year ago. So I'm going to ask Kayla to actually share in the chat a link to the message we've already posted that goes through the benefits rather than going through them all here right now. After we go live, so after mid-October, we're not going to call it the HealthPass online portal anymore. We're going to call it the MaineCare Partner Portal. I will caveat that between now and October, we're still going to be calling it the HealthPass online portal when we're talking about functionality today. So if we are sending out messages that are telling providers to go to the portal to access billing guidance or talking about things you can do in the portal between now and October, it will still be the HealthPass online portal. This new name change is going to be in effect starting in October. But we are excited about the name change. We hope it's a little more clear about what it is and who it's for. So we need your help for a successful transition. We are talking about trading partners. Trading partners is a broad term that mostly refers to providers, but not only providers. Trading partners also include billing agents, health plans, clearinghouses, and business associates. But in effect, it's users of the portal, entities and individual users who use the portal to do your work. Everybody has a trading partner account is what it's called. So we have actions that we do need trading partners to take now to help us prepare and not wait until October to do it. And particularly this is around user accounts, email addresses, and responsibilities for people who have an administrative user role in the portal. We will be, in addition to these slides and the e-message, we will have training available coming this summer. We're still finalizing the training dates, but we will Share those training dates as soon as we have them. And we're going to have multiple sessions on each topic so that if you can't make one training session, hopefully you can make another training session. We will have recordings, we will have job aids. So we're putting together what we hope is a fairly robust both training and communications plan between now and mid-October to help everybody understand what's coming, what they need to do to prepare, and how you will use the portal after we go live. I just want to pause. Kathy, have any questions come in?
No.
Okay, so now we're going to get into the meat of it. So there are a few key impacts that are important for you all to know. And I'm going to sort of preempt by saying that for those of you who represent provider associations on the call, we are hoping that after this message or after this presentation and after the e-message come out, that you can help us get the word out to all of your provider members. That would be really helpful for us so that we can just make sure that as many people see this information and have what they need to take action as possible. So I'm going to run through these. Only administrative accounts are going to migrate. So many people have user accounts today. Only the administrative R7 accounts are going to migrate to have users have a user account in the new portal. Those same admin users after go live, so in October, mid-October, will then invite all other kinds of users to the portal, and the admin users will assign permissions to all other types of users, excuse me. Right now, I believe there are about 9 kinds of roles permissions that a user can have. And in the future, in the new portal, there will be about 40. And so that's why one reason why we can't migrate all the other kinds of users, because it's hard to map the 9 to the 40 and know what kinds of permissions everybody should have. But that means that admin users will have the ability to be a lot more specific and accurate in what kinds of permissions people should have in the future. And I should say that both that activity as well as all these activities I'm talking about and changes are really to help us improve the security of our systems and our data so that the right people have the right access both now and moving forward in the future. Another change.
Molly,
Yes.
there is a question
Okay.
wondering about how this affects out-of-state providers who need to use the portal, such as Children's in Boston or Children's Hospital in Philadelphia. The person who's asking is asking because their son receives a lot of out-of-state care.
I don't believe there's any difference in impact. I think that this all equally impacts everyone, regardless of in-state or out-of-state.
Thank you.
In the future, your username will be your email address. And that means that every individual user needs to have their own email address. So one username equals one email address. Right now, we have a lot of usernames that all use the same email address. So everyone needs to have a unique email address. And we will not be migrating any administrative accounts that are inactive. So where we haven't seen people log in a really long time. Okay, so what can you do? What can you do now and advertise to all of your colleagues and peers to have them do this too? And again, more detailed information coming. Please designate at least one active administrative R7 user per organization, ideally more than one, so that you have backup coverage. Confirm that each active administrative user account has its own unique email address so that we can make sure to migrate those appropriately. And start getting ready to figure out who you are going to invite as all the other types of users after go live. So who needs to be a user in the new portal and what permission level will they need to have? You don't have all the information to do this right now. You can start thinking about what users will need user accounts, but we have not yet shared the information with you to know what permission level they will each have, because like I said, we're going to have different kinds of permission. So we're going to, than we do today. So we will be sharing more information about what permissions will be available in the portal during training. We're going to share a template to help you organize all this information so that you can do that prep work before before go live, and then have your template ready to go after go live to invite all the other kinds of users and already know what kinds of roles they need to have. And everyone should keep an eye out for additional detailed communications, the announcement for more trainings that will be coming. We are also going to be monitoring on the back end. So we have a lot of reports that we're running to sort of check the status of all these different changes I talked about, which accounts are inactive, which accounts are using the same email address, and we'll keep sending out general communications and reminders, but we may also start emailing individual people and trading partners and organizations at some point if we feel like that person or organization needs to take some specific action, because we also want to make sure that you all are ready to go and that everybody is ready to go so that we have as little disruption as possible in people's ability to use the new portal immediately after go live. Okay, key takeaways. So why does it matter? We don't want people to lose access. We want to have there will be some administrative work that needs to happen after go live, but we want it to be as reduced as possible. And the earlier everyone can do this work, the smoother it will be for everyone. As I mentioned, we'll be sending out more information and targeted communications. You can take action now. You can ask your peers and association members to take action now and keep an eye out for more. Any more questions?
I don't see any.
Okay, thank you very much.
Thanks, Molly. Okay, so next up, we want updates from the Beneficiary Advisory Council, the BAC. And Rachel, I think you're doing those.
Yes. So hi, I'm Rachel Ward. I am on the Beneficiary Advisory Council. We're down to 9 members, but we are actively recruiting for new members to come join us. We were discussing our meeting frequency and duration. We decided just to leave things the way it was, bi-monthly for about 2 hours. There was a decision made regarding stipends, meaning members don't have to report it to affect benefit eligibility, which is super exciting because that was a concern for a lot of us. And we're currently, as members, reviewing the handbook so that we can improve it, make it with clearer language and more straightforward for people to use. We had a couple of meetings where we met with the public consulting group about the best way to get communication to members and where we receive that information, how we prefer to receive that information. And the goal is to take all of the information regarding that and use it to communicate the federal changes that are coming. So that's exciting that we are going to actually get that information to people the way they receive it. We had an OFI presentation that went over main care eligibility, the benefits, the application process, clarified the barriers and questions that are typically asked around enrollment. It was really well received. There was a lot of engagement and questions and interest. People were very engaged with it. And the feedback focused on making things simpler, clearer, and just simply more helpful. And then I think Kat's going to put a link to our meeting minutes in the chat. We won't meet again until June 2nd at 11.
The notes are not actively on our back webpage at this time, but I will send a link and they will be updated by the end of the week.
Thank you. Thank you, Rachel, and thank you, Kat. Any questions?
So I see Wanda's question. Previously, we were told that we did have to report them as income, but we've become aware that it won't affect eligibility. I think it's still a good idea to report it personally, but Kat or Sana could probably answer that more directly.
Yes, so as far as if you're getting a gift card from a store or anything, you don't have to report it, and it will be internally disregarded with OFI and eligibility.
And Eddie wants to know if we have an email. I don't think we have a direct email just for the BAC.
No, but you can contact us if there's any questions. And I can drop my email in the chat. Also Kat's email.
And I think I heard that the next meeting of the back is June 2nd. Is that right, Rachel? Okay.
Yes, at 11, from 11 a.m. to 1 p.m.
And we do have a survey if you have any topics that you want the back to discuss, or if you have anything that you want to bring for the back. We do have a survey on our back webpage. And Kat, if you can put the link as well.
Thank you so much. Any other questions? I know we are a little behind on our agenda, but I think we actually, Kayla, can fit in both the communications update and the last thing. So why don't I pass it to you?
Okay, that sounds great. I'm going to share my screen. I'm joined today by Vanessa DeWitt, my partner in communications over at OFI. And so Vanessa and I will be going through this presentation together for you today. Now you all should be seeing the front slide. Perfect. Okay. So Vanessa and I would like to give you all an update today on communications planning around the HR1 eligibility changes that are coming for MaineCare. We've spoken with this group pretty consistently over the last almost year about this topic. And so what we want to do is just give you an update on where we're at with the communications planning, and to also close the loop on our last meeting where Public Consulting Group, PCG, came to meet with the MAC specifically to get feedback on that plan. So we'll do a little report out and then just let you all know where we stand. So a look at where we're at in the planning portion of the communications project. We kicked off by holding a member survey starting in January, where we got broad member input on how we communicate, when we communicate, how often, what modalities we use. And then we spent the month of February doing subject matter expert interviews internally to make sure that PCG understood what we know so far about the CMS requirements with the HR1 changes. In March, we started holding member focus groups, and we also had PCG come to the MAC meeting on March 3rd to hold a focus group style session to get input from all of you on how we communicate and what things we should be keeping in mind when making this specific communications plan. And in April, continued to hold member focus groups. Where we're at right now is where that gold star is. We are this week holding follow-up member focus groups, 2 sessions, to show members what we've changed in some sample communication materials to confirm that we heard them in the focus groups and interpreted their feedback correctly, and to confirm that the changes we made are positive. We are hoping to finalize content in June. It is all dependent on CMS and the information that CMS gets us. But the plan is to finalize the communications content and general plan in June. And so we hope to have more substantial updates for this group in July around what the communications look like and how they'll be rolled out. I'll pause. I know this was my slide, but just in case Vanessa wants to add anything, in case I missed anything.
No, I think you hit it all.
Okay, awesome. All right, I'll move to the next slide, which I think is still me. The first half of the findings from the MAC focus group, these are the things that PCG walked away from discussions with all of you and how they packaged recommendations to us. So what they start off with is to tailor communications to different populations by using a variety of types of communication. So thinking through things like text and mail and e-noticing. Pairing written and verbal communications. And in order to do that, we'll definitely have to work closely with our partners to make sure that we're communicating what should be shared with members verbally or how best to share it. They suggest social media campaigns be used to guide members to the DHHS website and really pointing everyone back to our website as the trusted source of information. Messages need to describe how the information specifically affects the reader and what actions they need to take. We should tap into as many community-based organizations as possible, collaborate with health-related partners and physical conveners like libraries or other local conveners. Our partners may be able to reduce the number of calls coming in from members if we're able to equip our partners with all the necessary information to help members succeed. We should provide direct outreach to members and use a recognizable caller ID so that when we're calling, they know that it's us, and hopefully would encourage them to pick up. We should tap into the member material review committee that OMS hosts for the OFI letters to members. And the most effective message is the one that is shared consistently across all speakers. So what we're coming up with this communications plan will be crucial for us to share effectively with our partners, with providers, and the general public. And for the second half of the findings, I'm going to pass it over to Vanessa.
Yeah, so thank you, Kayla. The findings continued. There were some language access themes, so making sure that we have correctly translated communications are critical. So that's something we'll be putting a focus on. We were also looking at sharing communications with partners who can speak with members in their preferred language. So that was the feedback that we got, that it'll spread the information within the community more effectively. Also, and I think the other slide talked a little bit about this, but focusing on that partnership with community-based organizations with expertise in eligibility rules as a trusted resource. So those folks are able to better engage in that two-way discussion with MaineCare members, which will be helpful given the complexity of some of these changes, particularly around these immigrant populations that are shifting from a comprehensive MaineCare coverage to an emergency services coverage only. And also sharing information with the Ajambo newsletter, which is a free Southern Maine newspaper that's accessed by the immigrant communities. I had never heard of it until the findings of this focus group. So that was very interesting to me. And then a person's preferred written language. One finding was that it might be different from their preferred spoken language. So just making sure that some non-native English members, they may understand their preferred language verbally, but the reading and writing component that was highlighted as a finding that we should be aware of too. And also, so moving forward on how you all can help. So I'm sure you all know our office, we're committed to supporting Mainers through the implementation of these changes, making sure that people who are eligible maintain their eligibility, and we're reducing the administrative disenrollments that come about. So we're planning on communicating more broadly with clinicians, community groups about the changes, but we're making sure that it's a member-informed communication strategy, like what Kayla mentioned. So we're focused on that this summer, communicating with clinicians and community groups. I know people are asking, what can I do right now? So we say what you can do right now. Key messages for our members is that folks should continue to renew their eligibility and report changes as usual. So people shouldn't disenroll themselves by thinking, oh, I'm not going to be eligible. So encouraging people to do their renewals, submit their paperwork on time. Changes in eligibility, like a change in address or employment, immigration status, those sorts of things, they should be reported to the Office for Family Independence, OFI, the eligibility and enrollment folks. And MaineCare members, they should continue to use their healthcare benefits. If they have MaineCare, see their provider. They should use the healthcare that they have. The second thing that we recommend is that MaineCare members must make sure that their contact information is up to date with Office for Family Independence eligibility. So this is straight out of what we did during unwinding. We want to make sure that we have accurate contact information. It is essential for renewing and maintaining MaineCare benefits. So we rely on making sure we have that contact information so that we can reach out to MaineCare members directly to make sure that we can give them the specific information in advance to any changes that are happening. So it is absolutely critical for us to have their accurate phone number, email address, and their mailing address. A couple more items. So MaineCare members, they must read their letters to stay up to date with their eligibility. So we always communicate any changes to someone's eligibility in writing ahead of the change. So if someone's opted into e-noticing, they can check it through going to their My Maine Connection account. They receive a text letting them know that there's something that they need to go read within their account, and then they pop in and then they can read it there. If not, they will receive the paper letter in the mail, and we will always communicate those changes ahead of time to an individual if their eligibility has changed. And then the last item of what you can do now to help us and make sure to spread that message is while the federal eligibility changes will begin soon, they don't apply to all MaineCare members. So when they change for specific MaineCare members, we will communicate that change with folks directly in advance and through multiple ways. So sending them a letter, direct outreach through phone calls to an individual. We also encourage people to add the eligibility number into their cell phone to program it through. There are sometimes spam filters that can make calls go in directly to voicemail. So if folks program the eligibility number into their phone, it's less likely to go through and through a spam filter that can be sometimes aggressive from a different cell phone provider. But we'll text people, we'll send an email. We're going to have multiple ways to get in touch with folks about these federal changes. So that is coming for individuals. And again, it doesn't apply to everybody for most of these changes. Okay. And thank you, Kayla. So we want to share just tentative communications ramp for the communications coming from the Office for Family Independence. We're finalizing the communications timeline right now, but we want to just make sure that you have a sense of what we're planning. So in July and August, we're planning on a community partners briefing and additional connection points with the community-based organizations and those who work directly with members. And a primary focus of that outreach is going to be to those individuals that are going to be losing their comprehensive MaineCare coverage and shifting to emergency services coverage that have those specific non-citizen statuses for their eligibility. Those individuals are going to be losing that full coverage in October. So we want to make sure to do a lot of communicating around that. But also we'll be, working with you all to talk about what the upcoming work requirements are too. But the most immediate need is making sure that folks know what changes are happening to their MaineCare in October for these immigrant populations. In September, we are going to start with sending letters out in the fall to these folks that are going to be receiving emergency services only coverage. So that's called a notice of decision for us. That change is going to be in effect for October. So that's when the letter will go out after the other broad communication has happened this summer. And also in the fall, when we're looking at September, we're starting that mandated member outreach to impacted MaineCare expansion individuals. So we are going to be engaged in outreach that'll include direct phone calls while during that phone call pre-screening for potential exemptions from MaineCare work activity requirements, just to see if people are already doing an activity that would put them into compliance with these new rules. We anticipate this effort to continue ahead of each impacted person's renewal date in 2027. So we're planning to reach out to all the individuals at that point. And then, we're just going to continue to do that ahead of 2027 when these changes are going to be rolling out for individuals that are renewing their coverage. All right.
And Vanessa, just to be clear, the changes for immigrants who are impacted because of the change in eligibility for certain non-citizen groups, that goes into effect for all people impacted in October. But the changes around the work requirements will be staggered in 2027 based on when people's recertification happens.
That is
Okay.
accurate. Yep. So all of the immigration changes, those are going to be implemented in October. So letters will be sent to individuals in September about the change. And then absolutely, Kathy. So in 2027, as an individual's renewal comes up, if they are a main care expansion member and subject to these new work, education, volunteering requirements, we'll need to get some type of information on them to see if they are exempt, or here are the things that you can do to continue on to receive main care.
And then just two other things from the chat. One is just noting that, and I think you said this in some of your feedback around like what you heard in focus groups, but that even though people get notices, not everyone can read them, whether or not they're English speakers. People have literacy challenges. So, like, can you say anything more about support for people where that might be a challenge? And then also just noting that Maine Access Immigrant Network, and I'm sure others on the meeting today, are available and interested in helping with outreach to specific communities.
Yeah, I think that anytime individuals need support with understanding their letters, they're more than welcome to call us and we can walk through that with them. I think that it would be helpful for us to provide a copy of these letters of what we're planning on sending out to folks ahead of when the changes, so that you all can know what people are reading and what to expect. I know that's been very helpful for folks with this able-bodied adults without dependents. It's a policy within SNAP, and it's super helpful for different community-based organizations to know what type of letters people are receiving, because it can be very confusing. We have run the text by several of these letters of what we're sending to by people in the room that would be receiving these letters. So that's been one technique that I'm really happy that we're doing during this project, to ensure that our letters, like we're asking people, what do you understand out of this letter? Like, what, if you receive this, what do you think this says? So that's been a really critical point of feedback that Kayla and I have wanted to make sure we include in the development of these letters and communications. So yeah, I think that one of the things that we're going to do is make sure that people get a copy of the letters that are helpers. And also I would invite anyone that if there, is a literacy challenge, like they should reach out to us and we can help them in any way, because we want people to understand what their eligibility is. That's our primary goal.
Thank you. And I know we're about to run out of time, but real quick from the chat, there's a question around if you have an estimate of how many people will be impacted by the changes in October. And there's also a question about the engagement activities and how many people will be impacted by that. I think your previous estimate had been like 31,000 folks might be impacted by that change.
Yeah, I can put a link. I can grab the impact statement that had previously been released by DHHS. I think that there's going to be another impact statement that's going to be published this summer that provides other estimates on that. So I don't want to put the cart before the horse on sharing different data, but yeah, I don't think that there's any numbers that we're willing to put out there right now that's different than what's on the impact statement.
And then just a note that it might be helpful in July to share, hopefully by then you'll have a better sense, or in the fall, like how will people demonstrate that they are meeting one of those requirements and are exempt. So I don't think we have time to go into that right now, but we could do more about that in a future meeting.
Yeah, absolutely. We're trying to make it as painless as possible, just so you all know. Like, anytime we will be able to take like somebody telling us a thing versus an administrative providing a thing, that's what we'll be going with. But also following CMS rules of whatever we have to receive, to keep it short.
Awesome. And just a note that Kayla put in the chat, the survey, if you could click on that before the end of the meeting, this is our post-meeting survey that we ask folks to share, to fill out each time we meet. It does give us a lot of helpful information about meeting format and topics that we're trying to cover. And I know we're at time, but Rhonda, did you have another question?
Yeah, I just wanted to comment that it's not only important for people receiving MaineCare services to get this information. We have to be sure that providers, like primary care, specialist, eye, dental, that they understand the changes too and how that may adversely or improve their connection to their patients. So just wanting to be sure, I know we talked about that yesterday as well, just making sure that everybody's informed.
Yeah, that's a great
on the care team, so to speak.
Yeah, thank you. And I know we're at time, but just very quickly, I'll just say, as we're wrapping up, again, our next meeting is in July, and you should have that in your email as well. It is possible that neither myself nor Adam will be here, because I'm going to actually take a sabbatical, and Adam is going to be out on leave. And so we will be trying to figure out whether someone else can help with that. And that's related to, I do also want to note that we wanted to try to set up in our bylaws, we had created a steering committee for the MAC, which involves 2 additional positions in addition to the chair and vice chair, one around governance and one of like a secretary role. And so I'm going to be, if you're interested in any of those opportunities, please feel free to reach out to me. I'll send a follow-up email without an attachment so everybody gets it, hopefully. But also, I will also try to follow up with some of you one-on-one if you've expressed interest in the past. And thank you, Kayla, for putting in the chat what those 2 roles are. And then the other thing that is in the works is we need to now, hopefully you remember that we need to do an annual report from the MAC. And so the current plan is that I'm going to be working on a quick draft of that report where it talks about a lot of the changes that we've made to the way that we meet and some of the things we've instituted because we need to, because of the federal rule changes. And then we'll get feedback from folks, and then we'll share it out with the whole group to get feedback so that we can have it voted on in July. So expect to see that for the whole group sometime in early June is the goal. And I'm sorry for rushing that last part, but any last questions? All right, awesome. Well, thank you all. Appreciate lots of great information shared today. And I hope you all have get a chance to see some of the sunshine today. It looks beautiful outside. Bye, all.
Thank you. Bye, everyone.